PP, you are starting or should I start?
Yes. No, PP will start.
Okay. Let Mr. Raja start.
Yes, sir.
As per protocol. Yeah.
Just 1 more minute, sir. We'll allow people to join, then we can start.
That
That's
live
all.
streaming is happening, sir. Just use- Okay, so we are ready.
Yeah. Just hold on for a few seconds. Let's about 20, 30 people join. Or 25, 20. Yeah. Done. All right. Good evening, delegates. It's been honor to have one and all of you once again for this program under the Regain, which has been supported by Microlabs Limited. We feel extremely happy and delighted to have the 10th edition of this particular program, and it's been the season 2, and we have been trying to constantly try and do our best of our abilities to disseminate the knowledge with the support of our course directors. So I take this great opportunity to really thank Lieutenant General Dr. B.P. Varma and Dr. Vijay Kher for their constant support and encouragement to help us conduct this program. So I now request Dr. P.P. Varma ji to introduce the speakers for the day and then accordingly take the session from here. Over to you, Dr. Varma ji.
Thank you very much, Mr. Raja and Microlab for supporting this. And as you rightly mentioned, today we are in the 10th episode of landmark trials in the field of nephrology. And I think it is a constant support of Professor Kher that we have been conducting this and moderating this program for last almost a year. Today, we have got 2 very interesting but challenging issues in the field of nephrology. One is hyperphosphatemia and second is hyperkalemia. Both these issues are very challenging and it's difficult to manage them. As far as hyperkalemia is concerned, we all know that especially in dialysis population or pre-dialysis population, hyperkalemia is a big issue. Many patients get deprived of the benefit of RAS inhibitors or aldosterone receptor blockers because of hyperkalemia. Though we have got methodologies to treat acute hyperkalemia, but we do not have much to manage chronic hyperkalemia, which CKD patients, especially those who have got heart failure or diabetics, are prone to. Today, we have got 2 very learned speakers, very respected speakers and teachers of very long standing. We have got Professor Ajit Singh Narula, who has been General Narula from Army, who is Director of Nephrology at Fortis Hospital. And we have got another doyen, that is Professor Mahajan from AIIMS, who will be touching on hyperphosphatemia. Without much ado, I'll request Professor Narula to please go ahead. And I must also state, he has been a huge support to us. We only requested him a week back for this program. And in this short time, and despite there is some emergency at home, he has been very kind, typical Fauji, that he has come to deliver his message. I request Professor Narula, with a lot of thanks, to please go ahead.
Thank you, General Varma, for those kind words. My presentation may appear a little lackadaisical. It's because of the stresses at home, but I've tried to put together my thoughts in this presentation. When Dr. Kher asked me to speak on hyperkalemia, believe me, sir, I did not know it was for this oration or this presentation, and I prepared for hyperkalemia. A day ago, I spoke and they said, no, you have to speak on this master class, and it's not hyperkalemia, you have to speak on trials. And that's why this little lackadaisical presentation. The second reason why I think I was asked to speak on this is because in the hospital where I work, every second patient has got hyperkalemia, and every second patient is being exposed to some form of RAS inhibitors. And it's a challenge every day for us on how to find a way out. If you look at the incidence of hyperkalemia, if you look at the general population in the yellow bars, it's about 2 to 3%. But if you look at in the population that we deal with, that is people with resistant hypertension, diabetes, heart failures, advanced stages of chronic kidney disease, up to 50% of patients have some degree of hyperkalemia. In the next few slides, I'll first try to bring about the importance of treating hyperkalemia. Can I go to the next slide, please? Yeah. So hyperkalemia is not a one-time issue. It's a recurring issue in the life of a patient with chronic kidney disease and heart failure. Now, in this retrospective analysis of a large database from the United Kingdom, what they found was that in patients with chronic kidney disease, about 30% of patients have some, at one point in their lives, they have hyperkalemia. 22% or so of patients in their analysis had more than one episodes, and about 16% had recurrent episodes of hyperkalemia in their life of chronic kidney disease. Now, why should we be talking about potassium binders today? Because we know that potassium goes on this roller coaster U curve. Higher the potassium, worse is the prognosis, irrespective of the group in which you are dealing, whether it be a control group, a diabetic, a heart failure group, or a chronic kidney disease group. So that's why all guidelines, like General Varma said, they said that we must optimize RASI therapy in patients with chronic kidney disease and heart failure. And despite their proven benefit, we are still not able to achieve optimum RASI therapy because potassium comes in the way of optimum RASI therapy. Now, what is the risk, mortality risk to a patient who has hyperkalemia? If you look at this chart, on the left, you look at the baseline potassium of 5 to 5.5 and potassium of greater than 5.5. The hazard is about 1.1 to 1.2 of mortality. But look at the hazard if you discontinue RASI therapy, whether it be an MRA discontinuation or an ARB discontinuation or an ACE discontinuation, it is at least 10 to 12 times more mortality risk in these patients. So I think this topic is very appropriate that we should be talking about managing chronic hyperkalemia in our OPD patients. To put this in another way, if you look at this chart that I've shown you, whether it be chronic kidney disease or heart failure, if you withdraw RASI from these patients, they have a higher incidence of MACE events. Very often, what do we do in our practice? We withdraw or temporarily disconnect or discontinue our RASI therapy. Now, I'd like you to see the black bars. Black bars are those percentage of patients who died, who continued RASI. Blue bars are those who discontinued RASI. And the yellow bars are those whom we withdrew. So withdrawing doesn't sort of protect your patient, it harms the patient. So it's very important to have important potassium binders in our armamentarium. Now, what do we have till now? Till now, we had a low potassium diet, which is a separate topic altogether. We had diuretics. We had traditional potassium binders like the SPS and the newer potassium binders, that is namely peteromer and zirconium. Now, I shall first talk about sodium zirconium cyclosilicate, peteromer, and sodium polystyrene. And just one moment, I'll get you all off from here. Yeah. So what you find is that they're all binders. They exchange something for something. They exchange potassium either for calcium or magnesium, or they exchange potassium for magnesium, or they exchange potassium for hydrogen and sodium, like it is seen in zirconium. And the time of action is variable. It takes a few hours to days in SPS, while peteromer and the new kid of the block, the zirconium, is much shorter acting. The action begins much faster. So let's look at the trials. Now, I did not cover all the trials, but I've taken a few trials which emphasize the importance of these two binders, that is petiromer and sodium zirconium cyclosilicate. We cannot start this presentation without going to the first sodium polystyrene sulfonate, which has been with us for decades, for at least 4-5 decades. And this was based on a randomized trial on 30 patients, 31 patients. Based on their trial, we have been using this particular drug for decades now. And what did it show? It showed that when you use 30 to 60 grams of sodium polystyrene sulfonate, there was a fall in serum potassium levels vis-a-vis compared to placebo. But what it also showed that there was a higher incidence of side effects, mainly related to electrolyte imbalances in these patients and GI disturbances. In a large retrospect match cohort study carried out in Canada, in adults over 65 years of age, what did they look at? They had a patient group in which the prescription for SPS was given, and they had 20,000 such odd patients. They followed them up for 30 days and compared them to a cohort who had not taken SPS, and they found that there was a very large incidence of GI adverse events, the most serious being of colonic ulcerations and bleeds. I think this is why FDA issued a black box warning on the use of SPS in their patients. But somehow it is more popular in Europe and hardly ever used in the United States. Now coming to the next one, that is the petiromer. Now this was a landmark trial with petiromer in patients with diabetes and kidney disease who were proteinuria. This was a phase 2 randomized controlled trial, which was carried out at 48 sites in 5 European countries and involved 306 patients with varying degrees of GFR from 15 to less than 60. So all these patients had chronic kidney disease. The potassium was more than 5, and the potassium ranged from mild to moderate hyperkalemia, and all patients were on some sort of RAS inhibition. Now, what was the primary efficacy endpoint of this study? They looked at the mean change in serum potassium level at 4 weeks. And what did they find? That in mild hyperkalemia or moderate hyperkalemia, with the use of petiromer in varying dosages from 8.4 to 25.2 grams, there was a significant fall in potassium in these patients. And this persisted on the use of petiromer over a period of 52 weeks. In other words, petiromer is effective in reducing the potassium and in maintaining a low potassium level. Of course, it has got its own adverse effects. Like I said, the electrolyte imbalances, like hypomagnesemia. In a small percentage of patients, they go into hypokalemia. That is why the dose titration takes place between 8.4 to 25.2 grams, and constipation was a major drawback in these patients. After this amethyst diabetic nephropathy study, they moved on to another big study, that is the AMBER trial. Now we know that in many of our resistant hypertension cases, we are forced to withdraw spironolactone because of the fear of hyperkalemia. So although this study was small, but it was a multi-center randomized double-blind study, which took patients with resistant hypertension, that is those requiring more than 3 drugs for their management, and they took varying stages of chronic kidney disease. That is eGFRs varying from 25 to 60 they took. And this divided the patients into 2 groups, in those whom petiromer was given along with spironolactone, and in those whom spironolactone was given with the placebo. Now, where they did give petiromer, they found that irrespective of the degree of renal disease, whether the GFR was less than 30 or less than 45, they could continue the use of spironolactone, and they achieved a better control of blood pressure vis-a-vis those on placebo. In other words, while the AIIMS diabetic nephropathy trial showed that it is effective in reducing potassium, this trial showed that even if you use some sort of MRAs, you can combine it with a potassium binder for better control of hypertension without the fear of hyperkalemia. The third trial looked at heart failure patients. So we looked at diabetic CKD patients, we looked at hypertensive patients, and we looked at the use. Now we are going to look at the use of petromer in patients with congestive heart failure. So they took patients with chronic kidney disease, heart failure, and those who were on RASIs and divided them into two groups. That is those with mild hyperkalemia and those with moderate to severe hyperkalemia. So they gave them a dose of petromer starting from 4.2 gram BID till week 4. That is, they stabilized these patients. They brought their potassiums down to normal, and having brought it down to normal, then they randomized their patients to continue RASI or those whom they had to continue placebos without the use of petromer. That is RASI plus placebo versus RASI plus petromer. And they carried on this trial for a period of 8 weeks. And what did they find? They found that in the initial treatment phase, there was a significant drop in the levels of serum potassium, both in the mild and the moderately severe hyperkalemic patients. And when they put all the patients together in one group, it was significant, the drop in serum potassium levels. But this was not the end of the trial. I think what was more important in this trial was, what they did was 107 patients with moderate to severe hyperkalemias, they entered into a randomized withdrawal phase. That is, some people at the randomized withdrawal, they saw those who received petromer versus those who had not received petromer, had received only placebo. They looked at patients with recurrent hyperkalemia for 8 weeks after withdrawal of the drug. The blue line shows the placebo, the green line shows the petromer. In other words, the effect of petromer lasts beyond its use, beyond the duration of its use in patients with RASI, chronic kidney disease, and in heart failure patients. And what was even more important was, when you look at the placebo group, that is in blue, about 60% of patients required some intervention to bring the potassium levels down, while in the petromer group, less than about 16% of patients required some intervention to bring the potassium levels down when they were in the withdrawal phase. So I think what this study actually showed us was that petromer effect lasts beyond its use. Now come to this zirconium, sodium zirconium, that is now finding its place in management of chronic hyperkalemia. As you can see, these slides I have borrowed from AstraZeneca, and I'm not going to talk about the phase 2 trial, the phase 3 trial. I'm only going to talk about the harmonized trial and its extension, and also go on to the ZS005 trial, only because the harmonized trial was conducted primarily in the European and Western population, while the Z005 trial, a similar trial, was conducted in the Asian population. Now, this first paper was published in the American Journal of Nephrology in 2019. And what did they look at zirconium? It was a phase 3 multi-center trial, which was carried out in 44 centers across US, South Africa, and in Australia. So they first took 258 patients and they stabilized their potassium levels by giving zirconium 10 grams TID. Once the potassium levels were stabilized or they achieved normokalemia, then they were randomized in the ratio of 4 to 7, depending on the dose that they use, whether they use 15 gram, 10 gram, 5 gram, or a placebo, done in a double-blind phase manner. And all those patients who had achieved normokalemia in this 28 days of maintenance phase were eligible for the 11th month maintenance phase. And 123 patients were found eligible for the 11-month maintenance phase. This was the extension phase. The first harmonized trial looked at 28 days. Then they extended to about a year in those patients whom they could achieve normokalemia. So what did they do? The primary endpoint of this study was they compared the mean potassium levels between the placebo and each zirconium treatment group from day 8 to 29. That is, whether it is the 5 gram, 10 gram, or 15 gram, they compared it with the placebo. And in the extension phase, they looked at the proportion of patients with mean serum potassium less than 5.1 during the 11-month maintenance phase. Zirconium continued in the extension phase, but the doses kept on varying depending upon the potassium values. And the point to note in their exclusion was that they excluded patients from dialysis, for which they came up with another study, which I'll be showing after this. Now, this busy diagram, the only thing I want to emphasize is most of the patients were around 60 years of age. If you look at comorbidities, significant number of patients, about 60% of patients, either had chronic kidney disease, heart failure, diabetes, or they were on RASI medications. And these were people with chronic kidney disease with GFRs varying from 45 to 60. So they had a fairly good proportion of patients. And of the 121 patients who went into the extension phase, it was no difference. There was a significant number of patients, if you go into this medical history, who had chronic kidney disease, heart failure, and were diabetics. And in this 121 patients, you found a significant number of them were on RASI, some sort of RASI therapies. Now, what did they find with zirconium? That the effect was almost magical. In about 2 hours' time, they found the potassium levels had begun to fall. And in the maintenance phase of 28 days, they maintained a low potassium level on zirconium compared to the placebo, which is in the upper line. And when they extended it, they found that potassium levels were maintained when people were taking zirconium. Of course, the dose of zirconium kept on changing in their population depending on the values that they got. When they looked at the subset of patients, those with chronic kidney disease, and GFR, very low GFRs, those with heart failure, those with diabetes, those taking RASI, they found that the fall in potassium was significant in all these group of patients. In other words, zirconium acted irrespective of the disease with which the patient was suffering. Then they further tried to analyze how soon can it be used for acute hyperkalemia. Now, this is very interesting. Now, if you look at the time in hours and the fall in potassium, you find that the potassium levels fell significantly after 4 hours of use of zirconium. Of course, it has not yet been recommended for acute hyperkalemia. It is still recommended for chronic hyperkalemia, but there is a study coming up where a combination of zirconium and other measures can be used for hyperkalemia. Now, when you look at the primary endpoint of the serum potassium during days 8 to 29, it was much higher in the placebo group compared to the zirconium group. And if you look at the number of patients who achieved a potassium level of less than 5.1, it was much higher in the zirconium group vis-a-vis the placebo group. Now, this, I think, is the most important slide of this whole study, that patients who were RASI naive at the extension phase could be initiated RASI on zirconium without the fear of hyperkalemia. And patients who were on RASI, some sort of RAS inhibitors, they could continue the RAS inhibitors in about 78% of patients, and about 8% increase the RAS dose to achieve the optimum effect in management of their heart failure patients. And of course, there was some concern about the bicarbonates, because even bicarbonates are exchanged with zirconium. But this showed that the bicarbonate level did rise a little, but it settled down to normal on discontinuing. So I'll not go to this because I think the summary is very clear that zirconium is a very effective potassium binder in patients with diabetes, in patients with heart failure, in patients with chronic kidney disease, and the next slide, which I'll show you, in patients on dialysis. Now, this is a phase 3 study, similar but carried out in the predominantly Asian population. It showed the same thing, that you could initiate RASI if a patient was on zirconium, you could maintain the same dose, and you could even increase the dose in some of these patients. A small fraction of patients did have to discontinue because they could not tolerate the zirconium. Now, this is the dialyze. This is the phase 3 again study. And this was again published in 2019. And what did it show? They took 196 patients. This is what Dr. Varma was referring to. They took 196 patients with end-stage renal disease who were managed for more than 3 months by hemodialysis 3 times a week with persistent hyperkalemia despite hemodialysis. And what did they do? To this group of patients, they added 5 grams of zirconium on non-dialysis days versus 5 grams of a placebo. They titrated the doses up to a maximum of 15 grams on non-dialysis days. And then they followed up these patients after maintaining them for about 4 weeks. Now, what were the outcomes? They found that these patients who were on zirconium, they were able to maintain their potassium vis-a-vis those who were not on zirconium. They maintained a pre-dialysis potassium of 4 to 5 following the longest interval gap between the dialysis. And they did not require rescue therapy to lower serum potassium. For what was the odds ratio of maintaining hypokalemia, of maintaining normokalemia, sorry, was 41.2% with zirconium. Then they looked at the rescue therapy. How many of their patients actually required a rescue despite zirconium? And they found it was exceedingly low compared to the placebo. The serious adverse effects was similar, and the interdialytic weight gain between the zirconium and the placebo group was also similar. So that could not have sort of affected the potassium balance. So this is something new which has come up on the dialyzed trial for the use of zirconium. And the final slide, it's really paradoxical, and I think it's clinically significant challenge because those patients who would benefit most from the treatment with RAS agents are those with the highest risk of adverse effects. Thank you very much.
Thank you,
Doctor. Thank you.
Thank you, Dr. General Narula, for that exceptionally excellent talk. And I know that I said it before that you keep on impressing me every time I hear you or I meet you. And I think we'll take the questions later. General Narula may have to leave for his personal issues at home. And I must again thank him for an exceptionally good talk, and especially highlighting the point that there is a need for management of chronic hyperkalemia, especially in patients in whom we feel that RAS inhibition is a therapy which is essential to decrease the mortality, to decrease the morbidity in these patients. But hyperkalemia does come in the way, and therefore we need to have a drug. And he has talked about these 2 drugs which we are very patiently expecting to come into the Indian market. At least one of them was expected probably in 21, but I think now we'll have to see this year. We see the light of it should be coming this year, and I hope that most of us should be able to use RAS inhibition in our patients, because that's an extremely important treatment modality to slow down the rate of progression of kidney disease, as well as decrease the cardiovascular mortality in patients with kidney disease and the other conditions that General Narula talked about: diabetes, hypertension, heart failure. All of these are associated very commonly in our patients with chronic kidney disease. Thank you very much, General Narula, and we hope to take the questions later. And we'll now request Dr. Mahajan, Professor Mahajan, to talk about the landmark trials in hyperphosphatemia. And as General Varma said, Professor Sandeep Mahajan is a very adroit, extremely knowledgeable person. Again, a good teacher. And we're very delighted to have him here, and we must thank him for agreeing to talk today. And he will talk about the landmark trials in hyperphosphatemia, again, an important topic of practical importance, and therefore it's important to know about this. So, Professor Mahajan, all yours.
Yeah, good evening, everyone. And thank you, Dr. Kher, for these very kind words. And believe me, once it comes from you, they carry a lot of weight. Also, I'm sorry. I will also like to thank General Varma for giving me the opportunity to be here amongst you all. And what I would be talking about today is, just a second, I think so. Landmark trials in hyperphosphatemia. So, are my slides visible now?
Yeah, they are visible, but you can make it full screen. Yes.
Yeah. Yes. So, well, unfortunately, I could not find a single trial which I might call as a landmark trial in hyperphosphatemia. Though, incidentally, we have a trial named the same, which has been published recently, which obviously I would be covering. So, with the permission of the chair, what I would do in next 20 minutes or so is to take a more pragmatic approach to this complex topic of hyperphosphatemia, and then fit in what all have been the important trials along the course of the talk. Well, the first and foremost question that arises is phosphate a toxin? What I would be covering is some very beautiful basic science experiments and some very robust observational data which links phosphate to mortality. I would be highlighting what I have just said, the great academic phosphate bypass. We unfortunately don't have very good trials linking phosphate as a causative agent for mortality. There have been few studies and a lot of meta-analysis. I believe there have been around 16 meta-analysis since 2003. Comparing various phosphate binders, I would be covering few important meta-analysis and studies. And then most importantly, talk about some new beautiful upcoming data regarding phosphate in CKD. And finally, some very beautiful trials which are ongoing and which might what we would call as landmark in near future. So, well, for everyone, everybody knows that kidney plays a very important part in maintaining the normal phosphate balance. And once you have chronic kidney disease, you would have hyperphosphatemia. And this is the original work by Mesri, published in 1970 and then 1979 as well, which basically tells us that as the GFR falls, you have increase in phosphorus, decrease in calcium, and then here the Mesri's trade-off hypothesis came in, that in the initial stages of a decline in GFR, this is well compensated by a rise in PTH, and once the renal function goes down, in spite of a rise in PTH, hypocalcemia and hypophosphatemia can't be corrected. So this is the conventional trade-off hypothesis. But we know, obviously, a lot of water has flown through in past 50 years, and we now know that trade-off hypothesis is much more complex than what was initially presented by Mesri. And we have a very important phosphaturic hormone, that is FGF23, which is secreted by bones, which also controls the vitamin D, the PTH, and the phosphate levels. And once the renal functions goes down beyond a point where even FGF23 does not help, you have hypophosphatemia. So this classically occurs in later stages of CKD beyond CKD3, not CKD2 or CKD3A maybe. So now, as promised, coming on to the basic experiments which prove that increased phosphorus can be a toxin. Well, this is a beautiful study published by Jono et al. In 2000. This basically looked at human aortic smooth muscle cells put in a media which was rich in phosphate with increasing concentration of phosphorus. And interestingly, they also did a mechanistic study for the same. And what they found was, interestingly, that as the concentration of phosphorus increases in the media, so there is increasing calcium deposition. So we can see that once the concentration increases beyond 1.6, and that is where we call it hyperphosphatemia, that is more than 5.5, you would have a milligram per deciliter, you would have progressive increase of vascular calcification, of progressive increase of calcification in the media. They interestingly showed that this calcification is actually mediated by phosphate-induced phenotypic shift in these smooth muscle cells. What happens is that these smooth muscle cells now start expressing the markers which are found in the osteoblastic or bone cells. And not surprisingly, this leads on to calcification. And actually, in real terms, calcification is basically phosphification. So it's basically phosphate which drives the deposition of calcium in the smooth muscle cells. And we know that vascular calcification is a very important complication leading on to increased mortality in patients with chronic kidney disease. Various other experiments have linked increased phosphorus to vascular smooth muscle cell apoptosis, vascular inflammation, endothelial dysfunction, and left ventricular hypertrophy, predominantly mediated through increased FGF23. And that brings us to this beautiful concept of phosphate being a toxin. So we know that phosphate can lead on to vascular calcification, can lead on to direct cell toxicity, can lead on to calcification, increase FGF23, left ventricular hypertrophy, and all that stuff. So we have some very good experiments linking phosphorus to vascular calcification. But does it lead on to increased mortality? Well, this is a very robust meta-analysis which was conducted by Palmer et al. And published in 2011, which basically looked at 47 cohort studies of patients, both with various stages of chronic kidney disease as well as those on dialysis. So they basically studied around 330,000 patients and looked at all-cause and cardiovascular mortality with all the chronic kidney disease, metabolic bone disease markers. So they have looked at phosphorus, they have looked at the parathyroid hormone, and they have looked at the calcium. And what they found was that the all-cause mortality correlated best with an increase in phosphorus. And for every milligram rise in phosphorus, there was an 18% increase in mortality. So from these experiments, we can safely say that hypophosphatemia is associated with increased mortality. Presumption is that it causes increased mortality because it leads on to vascular calcification, it leads on to so many more things. And if we treat hypophosphatemia, you would decrease the mortality in patients with chronic kidney disease. So this is an assumption with which we have been going on. However, this might not be a causation. It might be an association, meaning we know that those patients are hypophosphatemic are those who have inadequate dialysis. These patients have poor residual renal function. They also have poor dietary and medication compliance as well as dialysis compliance. So this hypophosphatemia and mortality story might not be a causation, it might be an association. And if that is so, then treating phosphorus is not going to lower the mortality. So ideally, once we have such kind of animal data, observational data, we should go in for interventional trials. And then once we establish this causation and not association by an intervention trial, we should include that in guidelines. However, unfortunately, in scientific committee, the phosphate has been bypassed. So we only have animal data, observational data, and then straight we have guidelines. And these guidelines have been coming for past 18 or 19 years now. Almost all the guidelines have been insistent that we should keep phosphorus to the normal levels in all stages of chronic kidney disease. Whether we look at the initial NKF DOKI guidelines, the Australian guidelines, the Canadian guidelines, the KDIGO guidelines in 2009, and then in 2017, we had for the first time some relaxation from the KDIGO. So instead of maintaining the phosphorus to a normal range, the guidelines now vaguely say that we should try to lower the phosphorus towards a normal range. So there's slight relaxation in the new KDIGO guidelines in 2017. However, in 2017, they interestingly added that calcium-based phosphate binders should be avoided at all cost, or should be avoided as far as possible. So we will come to that controversy subsequently. The latest nutrition guidelines by the KDOKI again suggest, because it's a nutritional guidelines, that by dietary adjustment, we should try to maintain phosphorus in normal range. So as you can see, other than the last, that is dietary adjustment, almost all of them are very, very weak grade of evidence. So once we decide that we have to lower the phosphorus, what are the ways to lower phosphorus? As we said, diet counseling is one. The other obviously is to give phosphate binding agents. Preservation of residual renal function, intensification of dialysis adequacy, and treatment of renal osteodystrophy are also other mechanisms, and they all should be combined. To have a good phosphorus control. But quite a few of them are not in our hands. So the best modalities would be dietary as well as use of drugs to decrease phosphorus. So now let's look at the few studies which I promised, which look at phosphate binders and then look at meta-analysis which compare the same. So this diagram basically shows the onset of various phosphate binders in clinical practice. In the 70s, we had aluminium. Then in 90s, we had calcium carbonate and calcium acetate. Sevelamer came in 2000. Then we had lanthanum. Then from Sevelamer hydrochloride, because it had significant acidosis, we shifted to Sevelamer carbonate. And then iron-based phosphate binders came. So this is roughly the timeline of various phosphate binders. This diagram here shows the important problems with most of these phosphate binders. Aluminium, we know, is very potent, cost-effective, but the biggest problem with aluminium has been the problem of aluminium accumulation, which has been linked to fractures, adenomic bone disease, dementia, anemia, and all that stuff. So we, our old-time nephrologists, once we started, we still had Oludrox gel, which was available to us. We used to give aluminium hydroxide in few patients who had very severe hypophosphatemia. It's a beautiful phosphate binder, but has so many more complications. Then came the calcium-based salts, calcium carbonate and calcium acetate. The problem with them is that they are not as efficient as aluminium, and you have to give higher doses. So it increases the pill burden. The other important problem with calcium-based phosphate binders is the long-term accumulation of calcium, which has been linked to vascular calcification, which we will be coming to that subsequently, and episodes of hypercalcemia. Because of the notoriety of calcium-based phosphate binders, we have been looking at non-calcium-based phosphate binders. And as we learned, Sevelamer was the first of the blocks. It's basically an anionic exchange resin. It's an artificial compound, which in gut binds to phosphorus by exchanging either chloride or carbonate, and then leads on to decrease in serum phosphorus. It's basically a calcium-free phosphate binder, but it's expensive, it's less efficient, and there you have to increase the pill burden, and it has significant gastrointestinal side effects. Lanthanum is a free metal which basically forms insoluble complex with phosphorus. It's potent, it decreases the pill burden, but it has to be chewed, it has a metallic taste, it has GI side effects, and then long-term accumulation of lanthanum is still unknown. We have burnt our fingers with aluminium once, and we are all skeptical about lengthening. Iron-based phosphate binders obviously have an advantage that they always provide iron in addition, but they are not as efficient, especially ferric citrate. The sucroferric compounds are more stronger phosphate binder, but it again comes with a significant burden of cost and GI side effects. So what has been the great phosphorus debate? The phosphorus debate has been that we know that hyperphosphatemia is associated with increased cardiovascular and overall mortality. But to correct hypophosphatemia, we are still not convinced that it's a causation or an association. All the phosphate binders come with a significant burden of side effects, cost, and pill burden, which is not very palatable, or which is not very important, which is not goes down very well with most of the patients. And also, once the phosphate goes out of bonds, especially in the West, these patients are labeled as non-compliant, and then the whole problem starts. Now, let's look at the studies which have looked at various phosphate binders. Unfortunately, this is not coming up the way I wanted it to be. This is the initial study which compared aluminium with calcium-based phosphate binders. Calcium carbonate was used. This was published in NEJM in 1986. And interestingly, it had only 20 patients, which were 1 month given aluminium hydroxide. They were given a break of 1 month, and then they were given calcium carbonate. And what they found was that calcium carbonate and aluminium both decreased phosphorus levels. And they also, the calcium-based salts also increases the serum calcium. So that's how calcium-based phosphate binders came into practice with a trial of 20 patients. However, as I said, there is a problem with long-term calcium use. This is a beautiful meta-analysis conducted by Boland et al., published in 2000, which looks at the side effects of calcium supplementation in general population who have been given calcium as supplements, nutritional supplements, to those who are 40 years of age. 15 trials, 12,000 patients, and a follow-up of around 4 years. What they found was that the patients who were given calcium supplementation had increased myocardial infarction. They had an increased risk, though non-significant, towards cardiovascular mortality, stroke, and relative risk of death. So what this meta-analysis showed was that calcium supplementation in normal population led on to increased risk of myocardial infarction and a trend to increased cardiovascular mortality and morbidity in general population. So obviously telling us that calcium as a supplement might not be as benign as we thought it used to be. And therefore the role of non-calcium based phosphate binders came. Just two important trials which I would highlight: Sevlamer versus calcium-based phosphate binders. The first one is the DECOR trial, which was a company-sponsored trial, and interestingly, the analysis was also done by the company persons. Around 1,000 patients in a multicentric open-label randomized control trial, 20 months of follow-up, which was a mean, which is a decent duration. And what they found was, again, some problem, but what I want to show was that all-cause mortality and cardiovascular mortality between the two groups, calcium-based phosphate binder and Sevlamer, were not different. Then what they did was they did a post hoc analysis, and they showed that in persons who were more than 65 years of age, there was a decrease in overall mortality, but non-cardiovascular mortality. So in persons who were more than 65 years of age, there was some benefit of giving Sevlamer over calcium-based products, but this was a post hoc analysis, not the primary endpoint. Interestingly, there was an insignificant trend towards increased mortality with Sevlamer in patients who were less than 65 years. So this got negated when the two groups were combined. So very interesting study. And this brought up another study, which was an Italian randomized controlled trial, the independent trial. This had much lesser patients, 466 hemodialysis patients, and they had a very vague outcome measure, 36 months or death censored analysis, which is a bit odd. For a trial you are looking at mortality, you are censoring for death. So I could not understand what they meant was that with that. Mean follow-up was 28 months. And the primary endpoint, again, very interesting, was cardiovascular death due to cardiac arrhythmias. So though the initial endpoint was all-cause mortality, but somewhere in between the trial, between the completion and publication, they changed the primary endpoint from all-cause mortality to cardiovascular death due to cardiac arrhythmias. So let's see what this trial showed. What this trial showed was quite astounding. So all those who have been into trials and who have been managing patients with chronic kidney disease, this would look like Amrit. So you give sevelamer and you reduce the all-cause mortality by 80%. You decrease the cardiovascular mortality and deaths from cardiac arrhythmias to the tune of 90%. We all know that all-cause mortality and cardiovascular mortality in dialysis patients is multifactorial. And all the intervention trials by a single intervention, whether they have been statins, whether they have been angioplasty, whether they have been reperfusion, they universally have been a failure in dialysis population. So this is an Amrit. Sevelamer, if you give according to independent trial, it's going to decrease all-cause mortality by tune of 80%, which is unheard of. So anyway, this leads on to various. This is a beautiful trial which has just been recently published, though not a randomized control trial. It basically looks at the US RDS data in hemodialysis patients who were more than 65 years of age. So they took off from where the decost ended. They studied only those patients who were more than 65 years of age and who were initiated on phosphate binder within 6 months of HD initiation. So 2,300 patients on sevelamer, 2,000 patients on calcium acetate. And the primary endpoint was fatal and non-fatal cardiovascular events, 3 years follow-up. And this, interestingly, was a propensity match study. So this is the best we can have from a retrospective observational cohort to a randomized control trial. So statistically, a very sound study. And what they found was there was no difference in fatal or non-fatal cardiovascular event or all-cause mortality with this in comparison of sevelamer to calcium acetate, as opposed to what was found in DECOR. And even if they looked at various factors like gender, the age more than 75 years, patients who had arrhythmias, the patients who had cardiovascular events, in all the subgroup analysis, this association was not found. So calcium acetate and sevelamer for 3 years follow-up was almost identical. And this is the landmark trial which I was talking about, published last year, which compared lanthanum with calcium-based phosphate binder. This is a multicentric Japanese trial, around 2,300 patients who had more than one risk factor for vascular calcification. That is, even if they were postmenopausal, aged more than 65 years, or were diabetic, they were randomized to receive lanthanum carbonate versus calcium carbonate, around 1,100 patients in each group. And again, there was no difference in the primary outcome, that was composite cardiovascular event rate, or the secondary outcomes of all-cause mortality and cardiovascular mortality. So again, this decent trial of 3 years didn't show any difference between lanthanum and calcium. So coming on to the meta-analysis, as I said, there are around 18 meta-analyses comparing various studies which have been so poorly conducted. 2 important RCTs I have included. One obviously is a Cochrane. And this is the first important RCT published in 2003, meta-analysis published in 2016 by Palmer et al. It was basically a network meta-analysis. The primary outcome was all-cause mortality. 77 trials, 12,000 patients. 90% were dialysis patients. The median duration was only 6 months. In these trials, the median duration was only 6 months. Almost all the trials had high risk of bias. Significant side effects was found with all the calcium-based, all the phosphate binders. And obviously, all phosphate binders decrease phosphorus as compared to placebo. The only significant difference was between sevelamer and calcium as far as all-cause mortality was concerned. And this difference became insignificant when you compare it with sevelamer and calcium. So the moment you discounted the independent trial. But most interesting thing is it at the bottom of the diagram, and that is in whatever trials we had, there was no difference between any phosphate binder and placebo. So even in dialysis patient, in this meta-analysis, though there is a lot of heterogeneity and bias, there was no difference between any phosphate binder and placebo as far as all-cause mortality was concerned. So now coming on to Bible of all meta-analysis, and that is a Cochrane review, which was published in 2018. It basically looked at all RCTs and quasi-RCTs. It had 104 trials as compared to 77 previously, and around 13,500 patients as opposed to 12,000 previously. And of these 13,000, more than 10,000 were on dialysis. The median duration is even smaller now, 3 months as opposed to 6 months. And again, almost all trials had a high risk of bias. What they found was, as compared to placebo, all these phosphate binders had no certain benefit on mortality, cardiovascular mortality, and cardiovascular events. All phosphate binders had high risk of side effects, which were predominantly gastrointestinal. Comparing sevelamer with calcium-based phosphate binders, all-cause mortality difference was there to the tune of 47%, but low certainty because the designs of the trials were so poor. So a meta-analysis can only be as good as the trial, and this meta-analysis actually lagged because the trials were very poor. They had lesser chances of hypercalcemia, but again, no certain benefit on cardiovascular and death and cardiovascular morbidity. Lanthanum versus calcium-based phosphate binders, there was no benefit in all-cause or cardiovascular morbidity and mortality. Coming on to the most recent trial, which was again published last year in JASN, which basically looked at tenapanor in patients with CKD5D in addition to a phosphate binder. So what these drugs do, these are basically inhibits phosphate absorption in the gut by blocking the phosphate absorption through the intestinal cells, just like nicotinamide or niacin. So what tenapanor does is it blocks the sodium hydrogen exchange portal in the intestinal cells. This leads on to high proton intracellular proton concentration, and that blocks the paracellular phosphate absorption. So this is over and above the phosphate binder, and this phase 3 trial in 236 dialysis patients did show significant benefit of using 2 drugs as compared to single drug in lowering the phosphate levels. Now coming on to the last and the most important part of the talk. What is the new upcoming data on the phosphate levels, and what are the important ongoing trials, which I promised could be the landmark trials? So first of all, some people have tried to address that what should be the phosphate target in CKD5D patients. Target trial is a multi-centric Canadian trial. Only 5 centers could be recruited. This was obviously investigator-driven. They could recruit 104 patients who were on calcium carbonate because that's the only phosphate binder they could afford. And they were randomized to titrate doses to achieve either an intensive phosphate goal, that is what is recommended by the guidelines, 2.3 to 4.5, or a liberalized target, that is between 6.2 to 7.75. The calcium-based phosphate binders were only given as a rescue if the phosphate went beyond 7.75. So other than that, they never gave phosphate binder in the liberalized target. The maximum dose of calcium carbonate given was 3 grams. And the primary outcome was the difference in change of serum phosphorus from randomization to 26 weeks. What they found was that even in the liberalized arm, the phosphate level actually stabilized to around 6.5. So it's not that the phosphate level touched the roof and crossed beyond 7.5 or 8. It almost staggered on to 6.5. But the most interesting part is here. The median dose of liberalized arm for a calcium carbonate was 0, as opposed to 6 tablets in the intensive arm. So you significantly cut down on the pill burden, the cost, and the supposed calcium-related side effects by simply having a more liberalized target of phosphate, that is 6.5. There was no significant difference in the calcium levels or major vascular events in this small follow-up of 6 months, and therefore, it is feasible to have bigger trials on the two phosphate targets. Interestingly, we had a similar study, the SPIRIT study from Manchester, and again it was investigator driven, and therefore they had only 2 centers in Manchester. Same number of patients, 104, the same targets, almost similar. So here they had 1 year follow-up, 2 months of titration and 10 months of maintenance. And the primary outcome was difference in serum phosphorus. Another important difference in this trial was that it used non-calcium based phosphate binders, either lanthanum or sevelamer, depending upon the standard practice of that particular dialysis unit. And what they found was that you could maintain a good difference between the two arms, around 1.1, that is approximately 2 milligram per deciliter. And again, the number of drugs required was 1 as compared to 8 in patients with with high target as compared to the low target. So what are the ongoing, or what we can call as landmark trials, which are going in phosphorus management? There are 2 important trials. One is a Canadian-based multicentric trial, which is the phosphate trial, and the other is a US trial, which is HYLO. Both are pragmatic trials, that is, they are not tight randomized control trials, but they believe in real-world data rather than a trial data. So they are predominantly investigator-driven. The sample size which they are now looking at is around 3,600 in phosphate and around 4,200 in HYLO. HYLO is a cluster randomized trial, that is, the center would be randomized to a lower target or a higher target. And the low phosphate target is 4.6 in phosphate and 5.5 in HYLO. And the high phosphate trial target is 7.7 in phosphate, almost akin to the target trial. The same investigators are actually doing the phosphate trial as well, and 6.5 in HYLO. The high phosphate, the primary outcome is cardiovascular death or non-fatal MACE in phosphate trial, and hierarchical hospitalized admission or all-cause mortality in HYLO trial. The phosphate trial is also looking at various patient-related factors like quality of life, the itch pruritus scale, the gastrointestinal symptoms, which are very important side effects of all the phosphate binders which we take. So, ladies and gentlemen, in the end, I would like to conclude that hyperphosphatemia has been linked convincingly with poor outcomes and cardiovascular events in CKD patients. However, it is still not established whether it's a causation or an association. The extent of phosphate reduction and type of binder to be used for optimal clinical outcome is still empirical and not supported by well-conducted trials, as I've highlighted. And until such informative trials are available, the patient with chronic kidney disease and the clinicians remain adrift in a sea of phosphate data which is available, which is not randomized, which is not convincing data, that lacks grounding by a suitable landmark trial, if I can put. Thank you.
Thank you very much, Dr. Sandeep. I think wonderful. I think this is what was desired, that we are totally at sea as far as management of hyperphosphatemia is concerned. As you very rightly put it, that even now the trials, high-low trial, our phosphate trials are going to decide what is the ideal phosphate level. Even the KDOKI guidelines of 2017, whatever, all guidelines have put it, try to maintain within normal level. There is no fixed data given. And as you rightly put it, that 2017 KDOKI guidelines even put it, that avoid calcium-based phosphate binders based on possibly flimsy data. This is also, again, what you very rightly highlighted, how the pharmaceutical companies can change the practicing trends of nephrologists. Today, the whole nephrology community is biased and not using calcium-based phosphate binders they are trying to use sevelamer or other phosphate binders on flimsy data of Dicot trial or Italian study, which were not randomized, which did not aim at all-cause death or the mortality in the patients. Now, I mean, now since everything is floating and gray area, which phosphate binder you prefer?
Sir,
Because let's assume most of the patients who are presenting to us in CKD, by and large, they come to us when they are requiring dialysis.
Sure.
So generally, the calcium content is lower in these people. Will you prefer calcium-based phosphate binders, or you still prefer sevelamer? Because today, if you see the market, 70% plus patients are on sevelamer.
Sir, if you ask me, the most important deciding factor for us in a government setup is cost. So calcium carbonate and calcium acetate come at 1/4 the cost of sevelamer. So that by default is the phosphate binder which we use most often in our OPD and dialysis population. The other factors which decide which patients go on what phosphate binder would depend on so many more factors. Elderly, diabetic, those on PD have higher chances of adynamic bone disease. So we tend to cut down on the calcium-based phosphate binders and at least try to put these patients on a non-calcium-based phosphate binders. This was the data from DECOR as well. That maybe elderly patients might benefit by giving a sevelamer or non-calcium-based phosphate binders. But younger patients, hypocalcemic patients, hyperparathyroid patients, I see no reason to go for sevelamer. I would use calcium-based phosphate binders. In fact, calcium carbonate, unfortunately, is so difficult to get. It's the most palatable of all phosphate binders. Minimum GI side effects. Whatever be the story about hypercalcemia it causes, I consider it's a factor. It was the cheapest calcium-based phosphate binders, and therefore it got replaced by calcium acetate, which in due time got replaced by sevelamer. So calcium carbonate got replaced by calcium acetate, which was more expensive, and that has got replaced by sevelamer. And very rightly pointed out, this is all pharma industry driven.
I'll ask Professor Kher, what is his choice of phosphate binders today?
I think
doing it, what the data is available.
Yeah, no. Well, let me tell you, I have, as Sandeep has rightly shown, over the last 2 years, especially since the guidelines about 2017, 2009 guidelines were all muck guidelines. Unfortunately, they've been really contested and derided by the scientific community to a large extent because the evidence base for this was very poor. Unfortunately, what happens is the practicing nephrologists don't look at what grade and evidence are they looking at. They look at the guidelines and they feel that as if that is 1A or 1B guideline, then start
That's
using
Bible.
And that starts like that is all these guidelines which Sandeep has shown correctly. None of them were about 3C. They're poor guidelines. They're very, very poor guidelines. And unfortunately, they should not have been guidelines at all. They should have said that there isn't any evidence and please go. Yeah. But 2017 was a more realistic kind of downsizing those guidelines. And they suggested that, okay, you can look at IPTH variable levels went up to 3 to 9 times the levels, the phosphorus and all. They gave clinicians, okay, you can do whatever you want, go as near normal, but be, even if it's slightly high, don't worry about it. And I think what I have done in my practice is I have started not worrying too much about the phosphate and looking at the pill burdens of these patients. My dialysis population, I tell you, now you can, large number of patients of mine whom I see unfortunately in our unit is not that everybody is being seen by me. So everybody will have a kind of sensitivity and sensibilities of these on a different level. But I, over the last few years, have started looking at phosphorus more leniently. I don't get excited that it is more than 4.5 or 5 and I would start jumping at it. I look at the number of pills that the patient is having. What is the kind of PTH is has? if the PTH is in a patient who has a significant advanced kidney disease, say stage 4, 5, and the PTH is 125 or 120 and 1, I would expect the PTH to be somewhere around 150, 200 or so and above than that. I get worried when I give either PTH lowering therapies or calcium binding phosphates to these binders to these patients, because there is a high chance that this calcium is going to go into the. So if I have to use a phosphate binder, I would use, as Sandeep has said, probably a non-calcium binding phosphate binder to them. But I can tell you that overall, I have also started telling students that please be liberal. Don't, most of our patients are protein malnourished. We have restricted them, and they don't eat foods basically because people get worried about the progression of kidney disease, phosphorus, and all other things. And many of these patients die of poor malnutrition and complications related to that. So I would agree with what Sandeep has said, that I think our message to the nephrologists, including all of us, we becoming wiser and wiser. And at the moment, till we have the trials suggesting what phosphate levels we should be looking at least unless you see other evidences, clinical evidences of calcium phosphorus complications, I would, if there are calcifications and all those kind of things, yes, I would be getting worried in these patients. But otherwise, I would be liberal. Don't be too much fastened about that you need to keep the phosphorus to 3.4, and because the guideline has said it that I have to be near normal, I would be more liberal about it and look at the overall comfort of the patient. And phosphate binders, tell me, if you, all of you must have faced it. If you ask patients what are the side effects, they say that this is one group of drugs which they find it extremely non-palatable. They find that this is the drug which should be avoided. They would want to get rid of this drug. So I would feel that we should be careful about the targets itself. And there is a learning. We don't know. Don't ask me what target at this point of time. But I have over the years become more liberal, accepting phosphates of 5 and 5.5. Also, when I don't necessarily get worried about is the phosphorus down or not. I have on the rounds in my dialysis unit also, I tell patients if they can't take phosphate binder, don't worry about it. It's okay. Okay. I'm becoming like that.
Yeah.
So it's a learning.
Possibly only.
It's a learning process. It's a learning process.
Possibly only if you are seeing the serial phosphate level. And
yes.
If you find the levels are increasing,
yes.
Possibly that is the time that there is a need to intervene. One point from Dr. Mahajan about tenapanor. Now, this is a new drug which is coming. As you said, this is NH3 blocker. So logically, your phosphate is not getting absorbed. At the same time, sodium is also not getting absorbed. So sodium is getting water. So diarrhea possibly may be encountered in large proportion of patients. I think maybe over 40% of the patients may have diarrhea. What would be the place for this? As you said, a combination, what will be its place? It sounds pretty good. The pill burden is very low. Dosage required will be 1 or 2 tablets a day. So where
in addition to a phosphate binder, sir. We all actually had some experience with niacin, which was available some time back. So flushing was a very important side effect, and that actually precluded us using it more frequently. And then some patients who could tolerate it, we found it to be very useful in decreasing phosphorus levels. Unfortunately, it was not meant for phosphate therapy, and therefore, because cardiologists stopped using it and it just went out of market. You don't have sustained release tablet of nicotinamide anymore in India. So this promises another almost the same mechanism of action that works through different receptors. It works through different receptors, but the mechanisms essentially remain the same, decreasing intestinal phosphorus absorption. Diarrhea, unfortunately, was the most important side effect even in this phase 3 trial. And that led on to more discontinuations in the treatment group as compared to placebo. So once we have our handle or our hands onto this drug, I think so. We would in a better position to use or tell us which patients we should be using the best. But our experience, at least my experience with niacin sustained release was also pretty okay.
Yeah. But I think Professor Kher also, we have also used Aludrox. You also must have used Aludrox.
Yes.
I have also used.
In cases where the hyperphosphatemia is resistant, I think a short
It was
course of
tremendous.
Aludrox is fantastic.
Oh,
2
it was
weeks,
a
4 weeks. 2 weeks, 4
yes.
weeks is enough to silence
Yeah.
all phosphorus.
To set it.
Yeah. It was an extremely good drug. Unfortunately, the aluminum toxicity, because it gets absorbed in patients with renal failure, therefore prevented its use. But I think it was a good drug, and is again not easily available these days. But if there is a resistant severe hyperphosphatemia, I would still use this drug wherever, if possible, to get it. Then this is extremely Ramban kind of thing for lowering phosphorus if it is very high.
I think Professor Amit Gupta has put a question to Sandeep. He says, possibly if we keep waiting for phosphate binders, waiting for calcification to set in before starting phosphate binder will be too late.
Good evening, sir. My take would be, sir, we still don't have a very convincing evidence that at least in humans, till 3 years of hypophosphatemia, we have significant calcification, which can be attributed to phosphorus alone. But as we said, the targets at which we should start phosphate binders are still unclear. 5 or 4.5 may be too rigid, sir. It decreases the quality of life of the patient, increases pill burden, make them more malnourished, and hence more prone for cardiovascular morbidity and mortality as to what would happen with phosphorus alone. So malnourished patients actually are the worst patients who do worse on any form of dialysis or conservative management. So my take would be that maybe I would start intervening once consistently the phosphorus is more than 5.5. A single value of phosphorus, I might not act and wait for at least some values, maybe after 4 weeks, after 6 weeks. Repeated values, if are high, then maybe I would start a phosphate binder. The other things which I would look at is the calcium and the parathyroid hormone. Again, if parathyroid hormone is skyrocketing high with hypophosphatemia, in these patients, I would try to intervene early. But blanket starting phosphate binding therapy at 4.5, 5 might not be a very convincing data right now.
No, as you rightly said, possibly serial measurements. And if it is showing an upward trend, yes.
Can we make Amit Gupta a panelist? I think he wants to make a comment. So
can he?
Yeah, he wants to make a comment. So Rajaji,
we would love to hear that, sir.
Deepak, can we have Amit Gupta be made as a panelist? It would be good to. Amit ji, unmute कीजिए अपने आप को.
And meanwhile, till Professor Amit Gupta comes, I think a question from both of you can answer the question which Dr. Narula was talking about. Now, what about zirconium and Pyromer he mentioned? Given a choice between these two, now there's no doubt that both are good. Both have got adequate trials. They are Pyromer has got Amber trial, Abinges trial, Opal trial, and zirconium has got harmonized trial, or dialyzed trial. Both are good. Possibly the difference is zirconium is acting throughout the gut. Zirconium starts acting pretty fast within 1 hour or so, whereas the Pyromer starts acting after 6 hours. Which one will prefer? The drawback with zirconium is edema, because once you have zirconium, it contains every 10 grams of zirconium has got 800 milligram of sodium. So that is, if you are giving 30 milligram, you are getting 3 grams of sodium. So edema is the side effect. I don't know, but they are not in the market. Comment from Professor Kher and Dr. Sandeep.
Whatever you might say, whether... Yeah, okay. you might say, Sandeep said that he works in a government hospital and cost remains an important factor in any place you work in this country. So irrespective of whether you are in a government setup or in a private setup, cost is the most important determinant. And I think in our country at the moment, what I see is probably that the likelihood is that zirconia is going to be available earlier than petromer. At the moment, it appears, but I don't know. The background market activities may be hidden at the moment and at least not visible to me, but it appears that AstraZeneca probably is going to bring, they've been working on zirconium coming into the, Localma is the trade name that they want to bring it here. And they've already applied to DCGI. So probably that's going to come first, but I think cost is going to be the determinant factor. And I also feel that it also will depend on the fear of hyperkalemia that people see. Clinically, see the trials have done that potassium of 5 to 5.5. Now, clinically, I'm not sure whether I would use a phosphate potassium binder at a potassium of 5.5. I don't think clinically my sensitivity for potassium starts somewhere around 6 and above.
Yeah,
I mean,
over 6.
I get
Dr. Kher, the
I
problem will
understand.
come.
Amit, I know I that potassium, if it is on a higher side, but potassium
No. What I'm
also,
saying is that your ability to use RAS inhibitors, you see, you would tend to start reducing the RAS inhibitor dosage once your potassium exceeds, say, 5.2 or 5.3. You see, you may not start an anti-hyperkalemic measure.
I don't necessarily stop it or reduce the dosage. I re-look at it again, because potassium, many times, at least in our patients, is most of these samples are sometimes sent 4 to 5 hours later. They remain in transit, and many times I find that the outpatient potassium and potassium of 6.57, I do an ECG in this patient. This was 3 days before. This patient has been doing okay, no clinically 6 potassium, 6.5 in my OPD outpatient. I do an ECG. ECG doesn't show anything. I do a repeat potassium, immediate potassium, to see if there is something. And I find that the potassium, actually the new potassium is 5.1. Now,
No, that may be true, but Dr. Kher,
yeah, that's what I'm saying.
Since this is an academic discussion, and the message that goes out to students is that we can accept a potassium of 6 and above, may not be very.
No, I'm not saying 6 and above. No, I don't think what you heard is right. What I'm saying is that I do not necessarily look at each and every potassium value. It will depend on the context. A patient who comes into the emergency has hyperkalemia. Obviously, that's hyperkalemia is
the
symptomatic.
advantage of having these drugs around, these anti-hyperkalemia, is that you can use your RAS inhibitors more freely without having
no
to
doubt
worry
about
so much.
that.
Point is well taken.
That has been highly
Yeah.
explained by General Narula. Was very, very good in explaining that why these drugs are important in our market.
I heard that
they
talk
need to
as
come.
well. That was wonderful, actually.
Yes.
Because the question is, as you rightly said, at the moment there is an inhibition that once the potassium becomes more than 5, you become reluctant to use RAS. And if it is more than that, possibly you stop it.
Yeah.
Now, one question which has been put up by Dr. Muzaffar Wani from Srinagar, and he puts to Sandeep that we don't know. He says, do you think there is a phenotype who are predisposed to vascular calcification? That will you be in order? What is your message? Should electoral X-ray of abdomen should be done to pick up vascular calcification, or echo should be done in patients to pick up valvular calcification? These are the two easiest modalities to pick up.
So if we have to look at the phenotype, I think the landmark trial is where we should go. It clearly states that the high-risk patients for vascular calcifications would be aged more than 65, postmenopausal, and diabetics. I think so. They have put up very beautifully the phenotype who are more likely to have a vascular calcification. So, and I would add the patients on peritoneal dialysis. So this is where I think are the phenotypes for increase vascular calcification as far as that is concerned. And that's where I suggested that maybe we should use a non-calcium based phosphate binder. The landmark trial with all these inclusion criteria was a negative trial on a 3-year follow-up. The second part which you asked was what would be the utility of doing a lateral X-ray and an echo to look at the valvular calcification? I think so. The KDIGO is also clear on that, they should have it at the baseline so that you know that who are the patients who have had a vascular calcification. At least for a diabetic, it's a good idea to have, because these patients can have vascular calcification even if they don't have an advanced stage of chronic kidney disease. So at least for all our diabetic patients, I do ask for an echo as well as a lateral X-ray. For a young male who is planned for a transplant, I don't think so I'm too bothered about vascular calcification at that particular scenario. So that would depend upon the further course and the clinical profile of the patient.
Our guest, Professor Amit Gupta, any comment on or any question on both the topics?
They wonderfully discussed both the topics. Regarding the point on edema that you mentioned with sodium zirconium, actually this trial that was done, the harmonized trial, actually looked at this question of edema and did not find any significant difference between the weight gain in the patients who were given sodium zirconium versus the placebo. So the concern about the edema was not really at least brought out by this trial, but although this trial was done by the industry. Regarding phosphate binders, see, as all of you have mentioned, is that we are sort of in a catch-22 situation, whether to treat or not to treat, and how rigidly or how strongly should we treat. I think we can't ignore hyperphosphatemia totally because of the pill burden. Unfortunately, we don't have a good drug as yet, but nevertheless, I think the phosphates levels above, say 6 and above, I would be sort of going ahead and treating them, as all of you mentioned.
Yeah, I think the message from today, before I hand over to Professor Kher for final comment.
But the point that I just want to ask is that, have you given up with calcium-based phosphate binders, ourselves, all of us?
No, that's what I'm saying, because the message from today is that whatever skewed data is about not using calcium-based phosphate binder is possibly not very correct. And as Sandeep brought out, is largely industry-driven. And they have not been able to find any difference. Even the USRDS data, which has a lot of patients, they have not been able to find out over a follow-up any difference in all-cause mortality or cardiovascular mortality. So possibly the myth that calcium-based phosphate binders are really very bad, they increase mortality, and the KDIGO guidelines, possibly one has to accept with a pinch of salt. So if required, my take on will be that do not hesitate to use calcium-based phosphate binder if you need them, whether it's a cost, whether it's a requirement of patient. Don't stop that KDIGO mentioned that not to use it. About the potassium, I think Professor Narula has very rightly mentioned and very nicely discussed about the 2 incoming potassium binders. And the time will tell, I think within a few months, one of the product, as Professor Kher was mentioning, zirconium, should be in market. And on the face value, it appears that zirconium may be little superior to pyromer. I'll stop here, thanking both the speakers wonderfully. They did a justice to the topic. I hand over to Professor Kher for his final comments on today's discussion.
No, I think coming to what Amit was saying, calcium phosphate binders still remain, at least in my practice, 50% or more patients are still on calcium binders as a calcium-based phosphate binders. So they continue to remain commonly used as such wherever you want it. But as I said earlier, that over the years, this new knowledge, which Sandeep has very, very elegantly described today, and I hope that I agree that phosphate is a toxin. At least the experimental evidence that he showed, as well as the human data in normal population, epidemiology of phosphorus across the Framingham study and all suggest that increasing phosphate levels are associated with mortality. But the question is that reduction of phosphate hasn't led to any change in the mortality, whether it is cardiovascular mortality or at least in our patients. So at the moment, that remains still to be proven, that whether lowering phosphorus is going to be helpful in our patients. We believe that it probably is toxic, and therefore we would not want it to go too high. And therefore the levels are still being discussed. I don't know what level would be ideal, but I think 6 is a reasonable clinical ground to go, that beyond 6, at least use phosphate binders, but don't kill your patients by the pill burdens that you give to these patients. And I think that's important. And these are drugs which have a lot of side effects, adverse effects. At least the patients don't tolerate these drugs. And I think that would be very well taken. What Sandeep said is, we don't have to be extremely fixed in our ideas about it. Be open to science. Science keeps on opening up new windows to us, and it shows the same thing that we used to believe previously. Now we look at it differently, and we believe that, oh, we were all wrong what we were doing previously. And I think that's the importance of science, and we should keep our eyes open to that. Potassium, yes, no doubt. RAS inhibition, you getting new mineralocorticoid receptor antagonists now, finerenone and others, which are again going to come. They may not be as severe on the potassium as the regular mineralocorticoid, but still they will have some effects on the potassium as such. So using these drugs now into our armamentarium and such is going to require that we need to keep potassium under control, and at least not so that we can optimally utilize these drugs, which are extremely important for reducing cardiovascular and overall mortality in our patients. So I think there's no doubt that today's talks were extremely eye-opening, very well done, both of them, General Narula and as General Varma said. And Sandeep, thank you very much for doing it so well as always. So, and then General Narula is not here, but we will again like to thank him for accepting our invitation and doing it at a time when his personal family was at some kind of a stress itself. Thank you very much. And I must thank also
Microlab also.
Microlabs.
That today is the last.
Mr. Raja. Yes. Yeah, I think that ends the landmark trials, and I would guess that we should thank them for bringing this. I do hope that this discussion for 1 year about the landmark trials, at least for the students, brought out what were the various important trials on various topics in nephrology, and these get discussed during the exam very, very often. And I hope that they found it useful, and I do hope that we'll continue to bring different dimensions of teaching to them, and I do hope we continue to. So keep yourself tuned in, and as General Varma has already circulated, there's going to be a different format of clinical discussions regarding particular case-based discussions. So that's going to come forth. So keep in tuned. Thank you very much. And I would like Deepak or Mr. Raja to close. Thank you very much. Thank you.
Thank you,
Amit. Thank you, Amit. Amit, for participating.
Thank you so much, Amit, for allowing me to participate.
Mr. Raja.
Yeah. Sir, I think it has been a very interesting journey because last year during the first wave, we had the opportunity to associate with you and then get the PG program started. But we gradually escalated this to the senior consultants as well as students level. So wherein this landmark trials in nephrology had been really impactful. We've been constantly getting a lot of queries, particularly from the students program, constantly asking us to go share the recorded sessions, or rather they would like to participate into the program in future. So I extremely take this opportunity to thank sincerely Dr. PP Varma as well as Dr. Vijay Kher for being the course directors of this program and helping us to guide on a constant basis. I also take this extremely most important that we need to thank all these speakers who have spared a lot of their valuable time during this entire 1 year for this particular program and helping us share this knowledge to the students. So this will be the last program for this particular season. But nevertheless, we are working on the next level with the guidance of Varma ji and Vijay Kher and probably Dr. Sakuja sir will be shortly coming out with our next program. So until then, thank you very much. And I take on this as an opportunity to thank Mr. Deepak Sharma, Mr. Vijay, and the entire the managers teams of the nephrology team of Microlabs who have been also constantly helping us to take this information to the doctors. Thank you very much.
Thank you. Thank you very much.
Thank you.
Thank you.
Thank you.
Good night. Bye-bye.
Thank you, sir. Good night, sir.
Good night, everyone.